As the dog has had its first season, the incision site is just below the umbilicus. The reason for this is that will make exposure of the ovary easier, but harder for the uterus, but the uterus should be larger. The fat was blunt dissected and trimmed off over the linea alba, giving better exposure. Use of 2 forceps helps you grasp the linea alba securely, ready for the stab incision. Keep the scalpel handle parallel to the body. It is fairly easy to miss the linea alba by a few millimeters. You can see how I missed it with this dog, and to rectify this mistake, by trimming the peritoneum as close to the linea alba as possible. Below the peritoneum, there is often a film over the abdominal contents, which you just break through with your finger. Slide your right index finger down the body wall, with the abdominal contents behind. Touch the vertebrae, then slide back up with your finger hooked. Just cranial to the bladder tends to be the best area, due to minimal intestine presence, usually just the colon and the uterus present. As she is a little tight, I have to push down on the body wall to get the ovary. If you pull hard on the uterus, it can break, but is okay to pull hard on the ovary. This is because the vessels are protected by the suspensory and renal ligaments. I had the ovary in my left hand. I transfer the ovary to my right hand and hold it under tension. My left index slides down the suspensory. Passing laterally to the kidney, I push down on the rib insertion. Once perfected, it breaks in seconds. Now make a low window in the broad ligament. Keep the uterine vessels with the uterus. Choose a transparent area so you don't damage any vessels. Place the ovarian clamp, preferably a Carmalt clamp. Walk the clamp down the ovarian pedicle, remove anything that shouldn't be in it, and then clamp once you have it a good distance from the ovary. Apply 2 clamps above the ovary, cut between, and now the uterus is separated. We now place the first millers. Keep it loose so you can nudge it deeper. Then once it is away from the clamp, rotate the clamp and tighten. Follow with about 5 to 6 singles. When you pull the miller's tail through, it goes back in the same direction, like it was initially. Nudge the knot down, using atraumatic dissection forceps. Rotate the forceps so the knot will bite lower down, and then tighten the knot as much as possible. We now remove the top clamp and hold the ovary as we raise the lower ovarian clamp closer to the ovary, making space for the second millers, which is now placed. Once the knot has been lowered, I place a pair of curved forceps through the handle of the ovarian clamp. This keeps the clamp rotated. We now remove both clamps and check for bleeding. Once satisfied, they are replaced and the ovary is cut off flush with a blade. We have already checked for bleeders, so we can confidently release the clamp. We keep the uterine vessel with the uterus and find a transparent area low down. This is where we separate the broad ligament and tie off with a surgeon's knot, or a miller's if the broad ligament is thick and fatty. Now trace down to find the other side of the uterus. Push down to grasp the ovary in your right hand and keep the tension on the ovary. Use your left index finger to slide down the suspensory ligament, tracing it as it runs laterally to the kidney. The suspensory on this side is thicker when compared to the right. Go as close to the rib insertion and push downwards. If this doesn't break it, try pushing it upwards. Or try pushing laterally to break into two pieces and then push down on these. Breaking the suspensory can increase exposure of the ovary by up to 2 inches, making life a lot easier. Now make your window through the broad ligament. Stay clear of the major ovarian vessels. Keep it low so the knots can be placed low. Always go for a transparent window. If fatty and difficult to see, press your glove against the broad. Now walk your clamp down past the ovary, giving you good exposure. Check nothing else is caught in it before fully clamping. I tend to give it 2 to 3 clicks, so not to damage the pedicle. Now apply 2 clamps and separate the uterus. Place a miller's loosely below the clamp, nudge the knot down. Rotate the clamp and then tighten the ligature. I place a pair of forceps through the ovarian clamp handle to keep the clamp rotated. The top clamp is removed and then the ovarian clamp raised. Keep feeling the ovary to ensure the clamp clears it well. The second miller's is loosely placed. Nudge down and then the clamp rotated and the knot tightened. Now both clamps are removed, and I check there is no bleeding whilst holding the bursa. Now the ovarian clamp is replaced, and I use a blade to ensure the ovary is cut off flush to the clamp. Form the window in the broad ligament, keeping the uterine vessels with the uterus. Double clamp, cut between and place a ligature below the clamp. If the broad ligament is small, use a surgeon's. If large and fatty, use a miller's. Some vets only tear the broad ligament, but I prefer to have no blood, rather than some and assume it's from the broad. Don't pull too hard, as this could damage the uterine vessels. What I am doing now is tearing a little more of the broad ligament off, so I can exteriorize the uterus a little more. The uterus was closed initially with a surgeon's, followed by 2 millers. The surgeon's was placed first, as less likely to cut through the uterus. I don't use crush beds as I feel the damage they can cause outweigh the benefits. I cut about 1 centimeter behind the last ligature, occasionally referred to as the golden centimeter. To check for bleeding, use a clean swab and swab down to the kidneys. You only have to swab one area. If there was a bleed, the entire abdomen would be filling with blood. We will close this one with simple interrupted suture pattern. Now is the easiest time to place the cranial and caudal sutures, and then place the rest in between. The advantage of simple interrupted is the safety. If one suture knot breaks down, we will not get herniation. The disadvantage is that you are more likely to get muscle swelling when compared to a continuous pattern. This is a trick you can do with simple interrupted. You keep the long tail of a suture to raise the muscle and pass the needle through, rather than raising the muscle with forceps. Once through the muscle, you need to cut the tail of the previous suture. We now start the continuous layer of the fat. Start the opposite way to the direction you prefer to do intradermals. To hide the knot, go deep superficial and then superficial deep on the other side. And first pass of the needle needs to be deep superficial to cover the knot. When closing the fat, you can take a nick of the muscle. This helps to pull the fat down and reduce dead space. I finished with an Aberdeen knot. Tighten the loop by spreading your fingers. Grab the suture and pull it through. This then forms the new loop. I tend to do far more than the 4, usually about 7 to 9. Remember to tighten using the loop and at the end pass through twice, as this reduces chances of a breakdown, but 2 pass is more important in skin than the fat. Then pull upwards to stack the knot without gaps. We need to hide the knot with whichever technique that works. With regards this knot's position, I go cranially in front of the knot and come out in the intradermal position. I now perform a continuous intradermal pattern and finish with an Aberdeen, passing through twice at the end to make the knot more stable. His secret to burying the knot is if the needle glides through, the knot should follow. Next to the knot, I wiggle the needle to try and get an easy path to follow. I lift up the skin so the exit is far away from the knot, most importantly with an aberdeen. I pull slightly with the suture, but mainly push the skin over the knot with forceps.